Good morning and good afternoon, everyone. Thanks, everyone, for joining in today's webinar. As you know, that we are having a monthly webinar series under Chorus Capacity Strengthening Activities. And today's webinar is about Introduction to Discrete Choice Experiment and a case study in developing a survey to elicit preferences for primary care provisions in Urban Dhaka. And so today we have two speakers. First, we will hear from Dr. Edward Webb. He's a researcher in health economics specializing in decision-making and preferences, including discrete choice experiments and other stated preference methods. He's currently based at the University of Leeds. He will discuss the discrete choice experiment and its importance and its applications in eliciting healthcare preferences. And later we will hear from Zahid Hasan, one of a course PhD student at the University of Leeds. He's from health economics background. Zahid will share his experience on the determinants. Determination. Basically, we'll talk about how the determination will determine the attributes and development of the choice sets for DCE to elicit preferences of, particularly with respect to primary care and in urban Dhaka context. So I'd just like to mention here that after the presentation, Edward and Zahid will have a 15 minutes discussion, question and answer, if anybody would like to ask anything and would like to know more about it. And you can share your comments and remarks in the chat box or ask the presenter later. So so without further delay, I would like to request Edward to share his insights on the DC. Over to you, Edward.
Indeed. Let me just... Okay, so can everyone see my screens?
Yes.
Brilliant. Okay, so so this is obviously going to be a two-part seminar. So I'm going to start off by giving a very general introduction to the topic of DCEs, and then Zahid is going to share some insights from his PhD. So for people who I haven't met before, I'm Ed Webb. After I completed my PhD in 2016, I joined the academic unit of health economics. And to my continual amazement, they still continue to employ me to this day. I do a lot of work on decision-making and preferences and valuation, often using these kind of stated preference methods like DCEs. Recently, I've been moving into doing some more sort of econometrics-y style work using large-scale survey data sets. Okay, so I'm going to talk to you today about discrete choice experiments. So in general, a discrete choice experiment is a research tool, which is a way of studying preferences in decision-making. It very specifically is a stated preference method. So it's about asking people what they say they'll do, and it's not necessarily about looking at what they actually do in reality. And like any other research tool, it has some advantages and disadvantages. So I'm going to start out by just giving a general introduction to the format and what a DCE is. And then I'm going to spend probably most of the presentation going through sort of the various stages of carrying out a DCE project. I'm going to finish off by kind of talking about some of the advantages and disadvantages of the technique. So hopefully you have kind of an idea about what it can bring and where it's most useful to do a DCE. So what is a DCE? Well, it's a tool which sort of developed in the 80s, and it was first in sort of transport and market research. It sort of started to take off in health in around the sort of mid to late 90s, and then has very much exploded since then. So this is a graph from a systematic review of all DCEs in health economics, which is published in 2019. So you can see it is getting more and more popular over time. So what it is a type of survey. So, and it also sounds really rather more complicated than it is. So discrete choice experiment is a very fancy name for something which in format is really quite straightforward. So we start off and participants are basically given a series of choices between two different options. These options are hypothetical, so they don't necessarily exist in the real world, but what they are is plausible. So the objects that you're choosing between will have similar characteristics to real-world objects. We describe these options in what's called attributes. There's typically about 5 or 6. Sometimes there's fewer, sometimes there's more, but 5 to 6 is probably the median number. And in the different choices that people make, the attributes change their levels. And this means that the objects that you choose between do change in the different choices. And then by looking at how people's decisions change when the choices, when the levels change, then we can work out how much participants value the different attributes. So this is an example I always like to look at. So suppose that we're not doing something very, very serious in health, but instead we're looking at something more fun, which is sort of pizza. So in this sense, this could be an example DCE of how we might investigate people's preferences for pizzas. So here we have a sample question. You're choosing between 2 hypothetical pizzas, pizza A and pizza B, and there's 4 different attributes here. So you've got size, the main topping, whether it's stuffed crust or not, and the price. And so you would give this choice to people, and people would look at it and think, okay, well, maybe I like, I like mushrooms more than I do peppers, and I'm £7 is quite a lot more to pay for something where I don't necessarily like the main topping that much. So maybe I'll just stick with a cheaper pizza. And then in the second question, you can see that the levels now change. And so now maybe you look at it and think, well, peppers are all right, actually, but I really don't like olives. And, 6 inches is a bit too small. I'm a bit hungrier than that. So maybe I'll actually, even though pizza A is a lot more expensive now, maybe I'll actually spring for the £15 for pizza A. And so what you have to do is look at these, and there's trade-offs between getting a bigger pizza and higher cost. And by looking at lots and lots of choices where people are making choices between bigger pizzas which cost more and smaller pizzas which cost less, then you can try and quantify this trade-off. And you can calculate things like the willingness to pay for each extra inch of pizza. You could also look at things like, well, are mushrooms or peppers preferred on average, for example? And also you can see things like, okay, well, actually, what's really driving choices? Is it that people are mostly being driven by what the main topping is, or are they mostly being driven by size? So how might this be useful in health, something which is like this? So this is an example for a current project where we're unfortunately not looking at pizza. We're looking at a rather more serious topic of non-surgical management of rectal cancer. So this is basically a mix of chemo and radiotherapy. So it successfully removes the tumor, so it essentially cures the person about 1/3 of the time. But there's clinical interest in using higher radiotherapy doses. This is referred to as dose escalation. So the idea is you give people higher radiotherapy, and that means that hopefully the chance of the tumor going away is higher. But on the other hand, a higher radiotherapy dose also means a higher risk of side effects. So that means that there's trade-offs between higher chance of cure and a higher risk of toxicity. And this means that the optimal treatment will ultimately depend on patients' preference. So you can run a clinical trial and you can get the evidence of, like, does dose escalation work in a practical sense? What are the downsides of it in terms of toxicity? But the optimal treatment will ultimately, you can't look at that using a clinical trial. So we're using a DCE alongside a clinical trial to try and address this question of what actually is the acceptable risk of toxicity in order to gain a certain chance of cure. And this is the survey instrument which we're using. So you can see, rather than things like whether it's got a stuffed crust or not, you're looking at number of patients with no cancer after 2 years. Okay, so that's a sort of general overview. So hopefully I've convinced you that, or at least I've given you a vague idea of what the format is, and I've convinced you that it can be a useful investigatory tool. So how might you carry out a DCE? Well, a lot of the kind of introductions tend to sort of go straight to something like this and say, this is a DCE, here's how you analyze it, this is what you get out of it. But actually, there's a very long development process before you actually get to something, a survey instrument like I showed you there. So I'm going to take you through some of these steps and show you why they are so important. So the first off is developing attributes. So developing attributes is really, really key, because if you don't include the right attributes, that really, really limits how you can interpret your results and how useful the results are going to be. So what you want to do is find attributes which are relevant to the target population. You want to make sure that you're including the most important factors that people really care about. You've got to ensure that people actually understand the attributes that you're giving them. And also, you've got to include enough attributes, or you've got to include the right attributes so that you can actually answer your research question. What you will typically do is use a wide variety of sources. And what's most useful is often qualitative methods. So you might do a systematic review of the literature, or even a non-systematic review, which will inform you in some way. But you would also typically do some sort of focus groups or interviews. You would get some expert opinion as well, which may just be people in the research team. And that would all feed in to give you a list of potential attributes. Although, I mean, you wouldn't necessarily be using all of these sources for every single project. Often you might. When you're doing this qualitative work, I think people often kind of overlook the fact that actually it's not just useful to develop your DCE survey instrument. It can be really, really informative in its own right. So this is just an example from a project that we did on treatment for multiple sclerosis. And we got this quite a lot of very good quality qualitative work, which in many ways was richer than some of the stuff that we got out of the DCE. And, you know, this is published research which is based just on the qualitative work. And I think it's very informative, told us a lot of stuff which the DCE could not. I've said that developing attributes is really important, which it is. I should say that there are some examples where you don't necessarily need this long qualitative process. So, for example, this is an example where we were looking at using a DCE to value EQ5D health states. So in that sense, the attributes are already well defined for you, because the attributes were simply the dimensions of the EQ5D instrument. But most cases, unless you're doing something very specific, you do need this long attribute development process. When you're going through this development process, what you will typically find is that you're going to have more attributes than you can actually include. So, you know, I said that really people can only really understand about 5 to 6 attributes. If you really, really push it, maybe you'll get as high as 10, but that's really, really pushing it. So you're going to have a list of you know, maybe 20 factors, and you can't possibly include all of them. So this means that you need some sort of selection process. What you'll typically find is that, in my opinion at least, this is often the most poorly documented and part of carrying out a DCE. And I think there is kind of a gap in terms of methodological research here. As part of a project, I did try to show how you could use a different survey method called the best-worst scaling and integrate that into doing a DCE. But really, there's not a great deal out of there. What people will typically do is a ranking exercise in some ways. This is often actually part of the focus group. So it's very common to use a focus group technique called nominal group technique, which then finishes with an individual ranking exercise. And that gives you an idea of the relative importance of the attributes. But on the other hand, ultimately, it's quite a pragmatic decision about what attributes to include. And usually you will have input from lots of different sources, because there's lots of tensions between whether you include an attribute and whether you don't. So you need to have attributes which form coherent options and can answer the research question. So you might include something which in your ranking exercise is not particularly important to people, but you really, really need that to answer your research question, in which case you might include it. And also you need to provide enough information that the choices are realistic. Okay, so that's sort of like selecting your attributes and the levels and everything. What you will often find is that if you search for discrete choice experiment design, what is this often referring to is what I'm calling the statistical design, where there's a large theoretical literature on this. Essentially, it means what attributes go where. So this might be an example statistical design for your DCE. So this basically says, okay, well, in the first choice set, alternative A, there will be attribute 1 will be at level 1, attribute 2 will be at level 1, and attribute 3 will be at level 2. On the other hand, for alternative B, attribute 1 will be at level 3, attribute 2 will be at level 1, and attribute 3 will be at level 1. So essentially, it's what are the options which you're actually presenting to people. And as I say, there's a very, very large theoretical literature on this. If you only have a very few attributes and levels, then what you might be able to do is what's called a full factorial design. And that gives you, that means that you present people with all possible choices. So here's an example where, say you have 2 alternatives, 2 attributes, 2 levels each, then that gives you 16 different choices, different possible combinations, and so you might be able to give people a full factorial design. On the other hand, if you get anything more than a very, very few number of attributes, this very quickly becomes impractical. So you can see where you've got, 2 alternatives, 3 attributes with 4 levels each, which is not actually that many, then already you're at around about 6,500 possible choice sets, which you need to present to people. And as soon as you get up to, say, 3 alternatives with 6 attributes and 4 levels each, which is like by no means a particularly unusual setup, then you're over a 1.5 million. So you can't possibly give people a full factorial design. So in other words, you need to basically select a subset, which is going to be a very, very small subset of all possible choice tasks. Most DCEs will now use what's called a D-efficient or an S-efficient design, which is very, very complicated mathematics, which I have to say that I'm not overly an expert in. But on the other hand, there is standard software to do it for you. So a lot of papers use this program called NGene, which is specifically designed to develop choice sets for discrete choice experiments. Or there are other packages as well. There's various packages for R, which will give you a DCE design. There's certainly packages in MATLAB, and I think there's some packages in Starter as well. In terms of when you're creating a statistical design, there's various things that you can do to make it easier. A common tactic, for example, is to say, okay, well, to make the choice tasks understandable for people, we're going to keep always, say, 3 out of 5 attributes. They're always going to be the same. So the options that you give people are only going to differ on a couple of attributes, and that's going to make the trade-offs easier for people to look at. It's also very common to exclude unrealistic options. So if something is just looks completely strange, then you wouldn't include them in your study. Often you'll have a set of attributes where it's fairly clear that people will always choose that a priori that people will like more of them, or they will like less of them. So you can think of, for example, in the pizza example, price. You would always expect that people, holding all else equal, will prefer cheaper pizzas. Or in the non-surgical management of rectal cancer example, you can assume that people will always prefer a greater chance of cure and will always prefer a lower risk of side effects. This means that you often end up with what's called dominant choices, where one option is clearly a priori better than all other options for all attributes, in which case you would usually exclude them. But the exception is that if you do have a dominant choice where, basically you know that people should be choosing one option rather than another, then you might include one choice with this as a test of respondent understanding. So if respondents end up choosing the worse option, which is very obviously worse, then you think, maybe they didn't get the question, or maybe they chose wrongly. So you can think about, well, do we want to potentially exclude this person's data from the analysis? In terms of sort of practically carrying out a DCE, they can be paper or online, and different methods will be appropriate for different populations. So if it's online, then it's obviously relatively easy to get quite a wide audience, and the marginal cost of recruiting extra respondents is usually pretty small. You don't have to go through data entry, and they can also be interactive. So, for example, you might funnel people into different options depending on some choices that they give you. An example for that is that we ran a DCE where we were specifically looking at reproductive issues. So we asked people, are you thinking of having children in the medium term at least? And only if they said yes did we give them the questions. So if they said like no, we were like, well, you're not part of our target population, so we won't show you the questions. On the other hand, with paper, there's no risk of digital exclusion. So as an example, our rectal cancer DCE, that's being done with people where the average age is going to be, we know is going to be quite old. I think in the data we've gathered so far, our median age is about 66, 67, something like that. And our oldest participants are in their 80s. So obviously, if you're doing stuff online, you might have quite a big risk of digital exclusion. Also, you don't need to do software programming or anything like that. And another thing which we're kind of talking, I find myself talking more and more about, is the risk that people, if it's an online survey, will try and do it on their phones. And this will be very, very, the DCE surveys are quite difficult to do on their phones. So if you've got an actual paper survey, well, we know that they've not done it on their phones. Whether you choose to do stuff online or on paper, the instructions and visual appearance of DCEs can have a big impact on your results, both in terms of results, quality, and other aspects. So you need to make sure that participants understand the task and understand the attributes. And kind of the goal of this is to make the choice tasks as clear and as easy as possible for people to answer. So, for example, this again comes from our rectal cancer DCE, and you can see that we used images to help respondents. And this was especially important because of there were risky attributes. But if you are including images, be very careful not to cause bias. So if you include, for example, images for only one attribute, then maybe their eyes are going to be drawn to that just because of the images, and their decision-making is going to be based on their eyes being drawn to a single attribute. And that kind of is going to bias your results. Images can also be incredibly important if the target population has poor literacy. So this is an example from a guy I know called Matt Quaife, and he did this in South Africa, I think. And that was with a population where he thought that a lot of people were going to have quite poor literacy. And so that's why he included lots of images to help people with that. You can also do some pre-testing. So I think that's quite important. So sort of think aloud interviews with potential participants. You can assess the survey length, whether they understand the DCE, whether you need to kind of change the choice sets to make them make more sense. You can also look at whether people seem to be ignoring some attributes, because that can potentially cause you problems down the line. And you can kind of assess what design features might help them. So this can potentially be a long process. So this is the DCE I was talking about with multiple sclerosis. We actually did about 30 interviews with one project to go from an instrument which looked like this to one which looked like this, and that people were much more comfortable with. You can recruit people to a DCE in many ways. So one of the easiest things is to just use a market research company. That's kind of good, especially if you want a sample of the general public. So you just phone them up and they will give you 1,000 respondents who are representative in terms of, say, age or gender of the general public. You might have access to email lists. You might really want to get onto partner organizations to help you with recruitment. You can do some recruitment. I've not had a great deal of experience or success with this, but in theory, you can just advertise generally on places like Facebook. For a paper DCE, you might be able to post it to people. You might just go knocking door to door and do sort of in-person interviews. Or like our rectal cancer DCE, we're actually recruiting people in clinics. So we've got some research nurses and research radiographers who are helping us in clinical settings. Also, many studies will use a pilot, so you can recruit about 10% of the data, look to see whether it's okay, and then revise the survey if there's any problems with that. Okay, so you analyze DCE data using what's called a random utility framework. What this does is basically you assign each option a utility that's partly based on its attributes and partly random. And then you assume the participant always chooses the option with the highest utility. And basically the estimation process is that you find the model parameters that maximizes the likelihood of observing the choices which people actually chose in reality. There's lots and lots of different ways to approach this. You can incorporate respondent characteristics, for example. There's also alternatives to random utility maximization if you're interested in those. One of them is random regret minimization. Probably just going to skip over this because we're getting I'm basically running out of time. And so I'm going to finish off by looking a little bit at the advantages and disadvantages of DCE. So hopefully I've convinced you that these are useful, it's a useful research tool, but on the other hand, it's not necessarily always the best option. And I think it's become more and more, in my opinion, that if you're addressing a broad research question, you should probably address it from many different angles. And so you should probably use a range of tools to address a given research question. The advantages is that you can do these DCEs where it would be unethical to get real-world data, it would be impractical to get real-world data. And also, it kind of gives you a look inside people's decision-making and preferences, because you might have real-world data on what people choose, but then you can't necessarily look at, well, what are the trade-offs that they're making between the different aspects of the treatments. In terms of qualitative research is really, really fascinating, but because this is quantitative, it gives you potentially greater statistical rigor than qualitative research. On the other hand, the disadvantage is you can only study a small number of attributes, and in reality, people will be making their decisions based on potentially on quite a lot more. The tasks are often, people can find them very difficult. This means that you will often have problems with getting biased samples. So it will tend to be much more higher educated people, sort of maybe more kind of mathematically inclined people. So that can be a problem. And obviously, I kind of criticized qualitative research a little bit above, but obviously qualitative research can potentially be quite richer, and you can get a lot of nuances out of it, which you can't with DCEs. Also, I'd just like to highlight that I've been talking about DCEs, but it may well be that there's other stated preference techniques which might be more useful. So one of those, for example, is best worst scaling. So don't necessarily go in if you're interested in doing stated preference work with absolutely, oh, and I need to do a DCE. Be aware that there are other options which might be better. Okay, so that is more or less all I had to say. So now I'm very happy to hand over to Zahid, who's going to talk about putting all of this theory and kind of general overview into practice. I should stop showing my screen as well.
Zahid Hasan. Okay.
Thank you, Ed. I'm just sharing the slide. Is the slide visible? Or?
Yeah, yeah. You can use a slide mode, slideshow mode. Yeah.
Can
Using the slideshow.
slide? Yeah, okay.
Yeah, we can see that. Use it as slideshow mode, slideshow. Yeah, it's great. Okay, but you still have your anyway, I think if you can, it's on the notes as well. So yeah, you can see the second slide. But anyway,
yes.
so if you know what you are doing.
Sorry.
Yeah, yeah, okay. Yeah, you can put it in.
Is it okay now? Yeah.
That's coming up yet? Not yet. Taking time.
I think the best way to do it might be to go into presenter mode, and then I think you can share the actual just the window rather than the screen for the full screen thing. I think that helps.
Okay. Is it okay now? Hello.
I mean, we can see the slides and everything. It's in the presenter mode and everything, but we can actually see the slides.
Sorry for share this.
Yes, brilliant.
Yeah. Sorry for it's sorry for the issue. So I'm going to just give you an overview on how I'm actually developing the choice set for conducting a discrete choice experiment in the context of urban primary healthcare in Bangladesh. So just let me start with a brief overview, like how urban primary healthcare works in Bangladesh. So urban community people, they actually visit different types of provider for seeking healthcare services. This includes like traditional providers, urban primary healthcare service delivery projects, and private chamber, outdoor hospitals, like government dispensaries, NGOs, and pharmacy and drug stores. So one of the recent analysis which I conducted found that more than 50% of the outpatients visitor actually visit to pharmacies in urban areas of Bangladesh for seeking their as a first point of for seeking the first point of care. So why a DCE study was planned under this research? So we wanted to contribute in developing a newer model of urban primary healthcare service delivery, basically which are being tried in Bangladesh in different formats, like by different types of different development partners like UNICEF and World Bank. So we wanted to explore that if we can contribute to by identifying what actually preferred by patients from the demand side aspects, so that we can contribute in developing this newer model of urban primary healthcare services. So how this contribution can be made? So we basically firstly will understand the stated preferences of urban poor population for different attributes of primary healthcare providers. So I hope that from the 8th lecture, you have already understand what actually attributes means. So for primary healthcare providers, the attributes will be a bit different rather than like the example of PICA and some clinical interventions. So the second approach is that drawing the attention of policymakers to consider demand-side preferences in policy decisions on implementing the newer model of primary healthcare services. So this is why we actually planned the DC under this project, my research project, my PhD project actually. So I actually I divided the steps in developing DC in 3 stages. So as you already have seen in the 8th lecture. So first one is the developing attributes. Then we will finalize the attributes and assign the levels of each attributes, and then design the choices. So currently I'm actually here. So I'm finalizing the attributes and for assigning levels and towards developing choices. So how I develop the attributes? So I had to go with a rigorous process of developing attributes, because this is not like a straightforward issues of like urban primary healthcare because the context is different in different countries, and although there are similarities in various aspects, but similar types of studies have not been conducted in Bangladesh before, only focusing on the primary healthcare services. There are studies like focusing on maternal healthcare or NCD healthcare, and or diabetes care for assessing the preferences for the patients. But so we did a systematic review of literature on choice of urban primary healthcare providers in low and middle income countries. So, and then we did some qualitative interviews with both the demand and supply side stakeholders. So through the systematic reviews, we developed a protocol. Then we registered it at a Prospero, and we have also submitted the systematic review at BMC Systematic Review Journal for publications. We searched like 6 to 7 databases like Embase, Scopus, Web of Science, Medline, Cochrane Reviews, and PsycInfo. And it's been about 3,800 articles, and then we ended with 65. We reviewed 65 full text, and finally we reviewed 25 articles which are included in our systematic reviews. From these 25 articles, we ended up with 184 attributes, and these are not these are mutually exclusive. So the different studies have like different attributes which are repeated. So it was like total 184 attributes from the systematic reviews. So we also conducted key informant interviews with program managers related to urban primary healthcare services and NGO clinic managers. I mean, NGO with the 2 NGO clinic managers. And the purpose of this conducting these interviews was to understand the urban health policy context in Bangladesh and issues, challenges with service delivery and their priority in delivering primary healthcare services and their future plans. So, and also we conducted in-depth interviews with service providers so that we can understand their what the priority in delivering services, what they focus on, what are their focus and importance, and what kind of challenges they face in delivering healthcare services, and what are their opinion on improving different aspects related to healthcare service delivery in urban area. So the whole purpose of this qualitative with interviews with the supply side aspect was to understand the context and to guide the developing or selecting the attributes so that we do not miss anything which is important and it is derived from the supply side aspects. Then we also want to go to the demand side aspects. So we conducted 4 FGDs at 2 slums of Dhaka city, which were Korail and Shampur. And we included in each of the slum, we had 2 FGDs, with one with male group and one with female group. And in each group, there was a mix of like a sick person who actually sought healthcare and the sick person who did not sought healthcare. So that we can get a mix of their views and their preferences and regarding their primary healthcare services. So the whole purpose was to understand their current practice of healthcare seeking of the community people in urban areas, and also to understand their preferences for healthcare and opinion of health service delivery. So from these qualitative interviews and from the systematic reviews, we actually we ended up with around 12 attributes. So which were like related to whether the facility is well equipped. I mean, having the doctors, nurses, and diagnostic services available, and the cleanliness of the facility with the cost of care for getting services, travel time to reach the facilities, whether the facility provider or the doctors or the nurse maintain privacy during consultation, whether the professional skill of the care provider, that means that whether the people actually wants to go to doctor or paramedics, and consultation time given to the patient, and attentiveness of care providers, reputations, waiting time, and whether the professional was known to the patients who want to seek care, or whether it is admired by others. So this is a long list of attributes we actually ended up from FGDs and systematic reviews and KIs. And this list of attributes is given the current context of urban primary healthcare service delivery in projects. So we selected these attributes, but this list we cannot. It would be difficult for conducting a DC having this long list of attributes, because as you have seen that there will be different combinations of each level and each attributes in different set of choices. So, and the urban people in a slum area, they are not that much educated to understand or comprehend the whole list of attributes. So we'll minimize this list of attributes in maybe in 5 to 6 so that it can be comprehensible to all of the people. So during selecting their preferences. So for this purpose, we will do another through FGDs to understand the ranking of identified attributes, so which we can include in the choice set. And also based on those attributes, we will understand the wording, which wording of the attributes will make sense to the community people, or how they actually comprehend the attributes we have selected, so that we want to make sure they actually select that, or they actually reveal their preference, their actual preference based on their understanding. And we will apply Engine software for generating the statistically efficient design choices with the selected attributes and level, and then we will finalize the survey tools. So this is in brief, very short presentation. And thank you for listening.
Okay, thank you, Edward and Zahid. Very comprehensive, and Zahid Hasan has really given a good example of Bangladesh, how it is being, and I could really relate to Irene's comment, and that how this thing, you know, from the focus group and qualitative study, are those attributes that came up are very quite similar to what WHO responsiveness indicators are there, what we really include in our the kind of building block of a health system. So I will just kind of really invite questions and any discussion on any other things from the audience, and the floor is open. If anybody has anything to say or anything to ask about the theoretical part, and also like the applied work that's being undertaken by Zahid Hasan. Over to you. Thank you. Any questions? I think it's look like yeah, Zahid, that's anybody would like to ask any question? Okay, so I'm just kind of really everything. The reason I'm just also kind of interested in this is a webinar, and I know all our chorus partner countries are really busy with their project one work, and this is a kind of, and also in introduction why it is important, and like making a decision, a choice, they're taking on health care services, this kind of study can help you to do that. But I mean, again, it's not maybe possible the way you have planned your research for your project one, and maybe some of you are thinking about project two. You can really think and relate of that, how this can be also part of your research research design. That's one reason. And at the same time, the other reason is, of course, this is one important area where we can really improve our skill and know that how we do it. And probably at some stage we will be really bringing out when Zahid will be able to come up with more of the results, and also the designing of the whole choice set, and see that, okay, what he has shown, that this is how I have developed, and then you develop the choice set. Again, I would like to bring some of the issues where particularly Edward has given the limitations and how you do it, particularly the qualitative and quantitative aspects of any research, and how powerful it would be, quantitatively doing, and of course there's always kind of a model and estimation and how you can use it. Yeah, and you can see that how particularly in low and middle income countries, and designing a choice set and implementing or collecting the data. And also this is important is the visual thing, where you can really, you cannot really understand. Sometimes you have to administer that in a people who can't read and write. So you can't, in many cases in low and very the Western world, is just send the questionnaire, even through online, people just click and then choice it, and it's so quick, and has conducted those study. It was possible. But again, in low and middle income country context, I remember doing one in Indonesia, and of course, where it's like, desk calendar, you just change the middle one, which is like one choice set, and the attributes levels changes, and then you can say that, well, this is the best choice. So it's a lot of experiment going on, that how to kind of put it together. So I don't know if Edward, you would like to share some of these experience where, in different countries, you have to really use this kind of whether paper-based and whether whether just online, and whether that's kind of a pictorial base versus purely writing down attributes. So that's a kind of an interesting example as you were showing. But Edward, if you'd like to share some of these things, that will be also useful. And I will come to Zahid and how it was, developing those kind of an attributes. And Edward, if you can say something on that, and would be a really interesting part of that, really designing and implementing the choice and experiment, I think. Edward, can you please?
Yeah, I mean, I have to say that for me personally, I don't have a great deal of experience of doing discrete choice experiments in countries other than the UK. So I think Zahid is probably more positioned to talk about that. But I mean, I'm sort of aware of that there are issues that it can be quite difficult to understand the choice context. So I think that's very, very important. And obviously there are potentially, depending on where you're doing it, areas around literacy and about recruitment and everything. So yeah, I mean, it is obviously it's extremely possible to do, and I suppose I think the advice would be to always partner with people in the actual country you're doing stuff in.
Yeah, that's a good point. Yeah, okay, so yeah, I mean, just again, I think Edward, that's a very important issue, that when you kind of dealing with the people and then bringing them and then really talking to them and find out whether this is possible. Right, so Helen, okay, Helen, I can see your hands up. Please, Helen. Yeah.
Oh, thank you, Zahid, and thank you for a really interesting presentation, the Zahid and Edward, really useful. I just wanted to know a little bit more about the sort of interpreting the final results, and how, if you have any examples of how to kind of present these and articulate these to policymakers to inform change. So I don't know if that's a question to Edward or Zahid, anyone who'd like to answer, really.
I'm okay to take a first crack at this. In terms of informing change, so informing policymakers, God, I would hate to think that my research was in any way sort of useful. I mean, I think this can be a really stuff like DCEs can be a really useful tool to inform policymakers. I mean, in terms of how you interpret the final results, that will very, very much depend on the context. But it could, so it could, for example, be that you might want to present the results in, for example, in terms of willingness to pay. So that might be if, if you have like a cost attribute there, then you might be able to show, well, here's how much people are willing to pay for a certain amount of or this is how much they would be willing to pay for a treatment which looks like this. So that can obviously be helpful. I'm trying to think of other things. Like, for example, we did a project looking at commissioners essentially for a certain type of program actually targeting childhood obesity. And so by doing that, we were able to demonstrate that, look, actually, there is really quite a lot of demand for effective programs to target childhood obesity. So that was obviously quite useful. I mean, there's various things like, for example, you might be able to, there's a growing trend to try and incorporate DCE results, for example, into economic evaluations, because it can tell you something about uptake and adherence, not only for the thing which you're evaluating, but it might give you information about how you might maximize uptake and adherence. So that's something, certainly something you could do on the policy front. There's also a growing trend that you can combine these this stated preference data with revealed preference data, and that can obviously strengthen the results. But yeah, so I think the broad how you should interpret the final results from a DCE, that's a question which is very difficult to answer, because it will very much depend on the exact context.
Yeah. Yeah.
Zahid, I don't know whether you want to say something about that.
Yeah, the same thing is, I can recall that I conducted a DC for the preference of NCD care and for maternal care providers. So what we see that people were like, the utility for preferring a qualified provider was more likely to like higher compared to the utility for preferring less cost. So the people were like choosing like professor or the qualified provider rather than choosing less cost. And we also find that there's no significant contribution with their waiting time or like in choosing a provider. So so this is how if we want to apply this these systems to the policy context, to the findings, so it has to be like decided to, for example, making availability of qualified care provider. So rather than just giving the free services, so that can be an important application, because people are choosing qualified provider without, rather than like offering for their expenditure. So maybe people would like to, as it said, we can see the willingness to pay. People may, for seeking primary care, they want to pay certain amount of fees and want to visit qualified provider rather than like getting free services without availability of qualified provider, because arranging care provider, qualified providers with free of cost is a difficult decision for policy implication with if we see from the aspects of financial aspects. So that can be an important like policy implications. Yeah, I'm not sure how I clear to explain this.
Thank you. That was really clear.
Yeah, it was. And it was really useful. Thank you. I mean, also like this question, Helen, you raised, this is very important, and maybe we can discuss this more. And I was just kind of a little bit afraid about the time, that we have already about 1 hour, and I have to just kind of take the office transport as well. But what I was just thinking about, I might bring this DCE kind of a discussion in one of the action learning group, or the quantitative group, probably. I don't know if anybody's interested within the course project period to do some DCE in any of the member countries, but it will be always useful to have a kind of a further discussion and have much more idea about conducting a DCE, which maybe sometimes at some stage may be useful. But as we know that some of the attributes, we can't have a lot of attributes and it's limited, but some of the policy context, some of the things becomes very important, and we can always test that, how people, or even the policymakers, there are DCE which has been conducted with policymakers, and would be really useful. That the question, Helen, you raised, that how the preference of the income groups and others, or even how the policymakers will take it. So we'll just stop here, and thank you very much, Ed and Zahid. And as I was about to ask, Zahid has given some idea. It's also useful to understand that how do you really engage, bring in people, talk to them, and write really can talk to them and then bring out all the attributes people read. And you can see the long list, but that's an important step of working on how to develop the choice set. Anyway, I'll stop here. If there is any other question, please let me know. Otherwise, I will stop here and probably would like to bring it in one of the ALD quantitative group discussion as well. Yeah, okay, thank you very much. Thanks.